Welcome to the North American Spine Society Annual Meeting, 2020 Virtual Edition. It is my pleasure today to talk to you about coding for cervical procedures. This talk is geared towards upper residents as well as fellows or first or second year spine attendings. I highly encourage that you guys take the intensive North American Spine Society coding course, as this is just but a brief overview. We go through a lot of our training learning the subject matter of spine, but when it comes to coding, we get very little training or education through the training process. So I'd like to thank NASS and the program committee to allow us to put talks like this together and to develop a program specifically geared towards our residents, fellows, and young attendings. Prior to delving into the coding details, I'd like to talk a little bit about my disclosures. Nothing that would bias this talk. I'm involved with NASS. I've been involved with them for over a decade. I also am involved with several of the societies, and currently I'm in academic practice and have a fellowship that I'm a director of. So let's start with just the right coding for spine procedures. Spine coding is complex. You don't want to undercode, as you will lose revenue, you'll lose value, and in fact, Medicare and CMS can audit you for undercoding and inappropriate coding. Certainly, you don't want to overcode, as that leads to denials, inflated accounts receivables, audits, penalties, and so on and so forth. It's important to understand and develop an organized approach to coding for spine procedures. So let's sort of develop a little bit of a framework before starting the actual coding process. It's important to understand the 4 elements for procedural coding for spine surgery. Think in your mind, why are you doing the procedure, as the primary diagnosis can affect the types of codes utilized and the payments and reimbursements for specific surgical procedures. The next thing to think about is, how are you going to go about accomplishing this? Meaning, what is going to be your surgical approach? Then also, it is important to discuss and think about the anatomic location. Is it in the cervical spine, the thoracic spine, etc.? And then you always want to start with main procedure code. So if it's a complex case or a fusion or a deformity, you'll likely code for your fusion procedure or your osteotomies as one of the first codes, as multiple procedures can often be subject to what they call multiple procedure code reductions. So you want to start off with your most important and significant procedural code. Let's talk a little bit about important definitions. So this can also change how you're going to go about coding for a specific procedure. So vertebral segment versus vertebral interspace, it's important to know the difference. For CPT purposes, the vertebral segment is defined as the basic constituent part into which the spine may be divided. So essentially a single complete vertebral bone with its associated lamina. So C4 would be a vertebral segment. Interspace is defined as the non-bony compartment or the disc space or interspace between 2 adjacent vertebrae. And this is important, as discectomies can be coded as an interspace procedure, whereas certain cases, laminectomies or certain decompressions with foraminotomies can be coded based on the vertebral segment that you're addressing. So as we mentioned earlier, it's important to develop an organized framework to coding all your procedures. This is a nice slide that was put together through an article that I read in Orthopedics Today. It's by Pollock and Romano, and they talk about 8 basic facts or 8 questions to ask before you start coding a procedure. So the first fact is, what was the approach? Second one to discuss is, which area of the spine was the procedure performed in? In our case, this talk will be really focused towards cervical spine, but this is discussing whether it was a cervical procedure, a thoracic procedure, and so on and so forth. Subsequently, you also want to determine which segments or which levels were operated on. Then there are those procedural issues to comprehend and to report. Was there a decompression involved? Was there an arthrodesis or fusion involved? Did you use spinal instrumentation? How about bone grafting for fusion purposes? And were there any other billable procedures that were performed during that same episode of care? So to start off with, generally, you want to know what your surgical approach was. In the cervical spine, you generally do either an anterior approach or a posterior approach. So anterior approaches typically consists of a discectomy, which is a form of a decompression, and there's often some sort of preparation for arthrodesis. We usually don't perform an anterior cervical discectomy without the arthrodesis, so these codes have become a bundled code at this point. Another anterior approach can be a corpectomy, which again is removal of a vertebral body. And you can't really bill for a partial corpectomy unless 50% of the vertebral body has been removed during the surgical procedure. Posteriorly, there are several procedures that can be performed in the cervical spine. Laminectomy is a commonly performed posterior-based approach procedure. Laminoplasty is also a unique procedure performed in the cervical spine. Arthrodesis, instrumentation, bone grafting, again, are other forms of procedures that can be performed using a posterior surgical approach. So again, it is important to know and to report in your operative report what your approach was, as most of us will end up doing our own preliminary coding, but those of us who are either in an academic practice or who have coders as part of your department or subspecialty groups, you still want to indicate which approach you utilized, as that'll allow your coders to fine-tune your coding and make sure you're not making any obvious mistakes that would be subject to audit later on. So what region of the spine? As we mentioned before, it is important to know whether you're operating in the cervical, thoracic, and lumbar spine. People who will be submitting your charges or codes, they will often review your operative notes, and they're not spine surgeons. They're coders, and they need some guidance as to which portion of the spine was operated on. The next question to ask or to determine in your operative report in order to code properly is whether or not a decompression was performed. And this is typically done based on diagnosis, as well as levels of interspaces or levels of vertebral segments that were involved. And again, you can do this with an anterior or posterior approach when it comes to the cervical spine. Anteriorly, typically it's a combination of a discectomy and an arthrodesis. In the older era, there were multiple codes that were utilized for the surgery. Now they're all bundled into a single code, which is fairly commonly used. The code is 22551 for a single level primary cervical discectomy with interbody arthrodesis. If you're performing a vast decompression that requires at least removal of a half of vertebral body or more, then you would code for the corpectomy code, which is 63081. Now we're going to discuss the posterior-based decompression procedures. Again, sorry for the dry subject matter. It's important to understand the approach as well as some of the basic and commonly used codes, and that's the goal for this talk. So when you do a cervical decompression using a posterior-based approach, again, you'll want to know what your diagnosis is. It's typically done for disc herniation or bony foraminal compression. If it is that, then you code by interspace. So if you are performing a posterior foraminotomy in the cervical spine, or if you're performing a posterior discectomy, which is typically only performed for a lateral-based soft disc herniation, then you would use a laminotomy code, which is 63020. In case you're doing a revision code, there is a separate code for that if it's a revision procedure. Vast majority of the decompression done posteriorly in the cervical spine is a laminectomy, and that is 63045 as a primary code, with 63048 being an add-on code. Cervical laminoplasty is a very unique procedure that works very well and is only used generally in the cervical spine. It is important to note that we typically do not do a laminectomy alone as a standalone procedure in the cervical spine due to the risks of post-cervical laminectomy kyphosis. So if you need to do a decompression and the patient does not require a fusion, typically a laminoplasty is performed. There are 2 codes available for laminoplasty of 2 or greater segments. Typically, it's done with some form of a reconstruction with plate fixation. Multiple companies have these laminoplastic plates, and the appropriate code for that would be 63051. If you're doing a cervical laminectomy for etiology other than degenerative conditions, spondylotic myelopathy, there are other defined codes. For example, if you're doing a laminectomy for neoplasm, there are extradural neoplasm codes. If you're doing it for an infection, there are certain codes that you can utilize that are separate. And again, this is why I recommend taking the intensive NASS coding course in your first or second year practice so you can familiarize yourself with the detailed coding procedures. Now that we've already determined what our approach is going to be, anterior versus posterior, whether or not you're doing a decompression, the next thing to discuss in your coding plan, as well as your operative note, is whether or not a fusion was performed. Again, as mentioned earlier, from an anterior approach, the discectomy, a decompression, and fusion codes have been bundled together, and that code is 22551. And that is because we do not end up performing a cervical discectomy without a fusion. That too leads to usually cervical kyphosis and deformity and other problems. If you've needed to take out a vertebral body, then you can code for a cervical corpectomy with an arthrodesis code that's appropriate. When it comes to fusions, you can also perform fusions from the posterior aspect of the cervical spine, and here you have an array of codes. The codes are dependent on the location that you're operating on and where you're performing the fusion. So for example, there is a separate code for an occipitocervical fusion, as that is a unique anatomy that has its own challenges, and that code is listed below as 22590. Similarly, if you're doing a C1, C2 arthrodesis, that too is a challenging environment and has a different unique code that needs to be built to differentiate it from subaxial fusion. So that's 22595. Any type of cervical fusion below C2 is coded as 22600 for one interspace, and then additional levels are coded as 22614. So you'll notice a pattern where cervical, thoracic, and lumbar spine all have a unique primary level decompression and a primary level fusion code, and then the add-on codes are typically the same across the various segments of the spine. So now that we've discussed a decompression and a fusion, the next aspect to think about and to discuss for billing and coding purposes is whether or not instrumentation was utilized. In modern day spine surgery, it is fairly rare that we perform an arthrodesis without instrumentation. Of course, there could be some patient factors that lead you to not want to instrument or do some external immobilization techniques. But for the purposes of a majority of our cases, there's always instrumentation involved. And that construct is primarily coded by the number of levels involved and the anterior versus posterior approach. So an anterior anatomical placement is a screw and plate fixation that's based on levels, and posteriorly, similarly, it's usually a screw and rod fixation that's based on the number of levels that are instrumented. So when it comes to the anterior cervical spine, and anterior cervical discectomy and fusion is predominantly done at 1 or 2 levels, and the instrumentation that is utilized for those codes or those procedures are 22845. When you're doing a 3-level discectomy and fusion from the front, that's typically a 22846 code. Many of us either will use a structural autograft or allograft for an anterior cervical discectomy and a fusion from an anterior approach. However, it is fairly common nowadays to also utilize a biomechanical intravertebral cage device, and that carries a unique code, which is 22853. It is also important to know that standalone devices with internal fixation attached to the standalone device are coded with just the 22853. You do not code an anterior instrumentation code separately, as there is no separate plate and screw placement with those standalone incorporated devices. If you're using a biomechanical cage device to reconstruct a corpectomy or a bigger defect, that code is unique as 22854. Let's talk a little bit about posterior instrumentation. Posterior instrumentation, again, can be done at a single level or monosegmental. That's considered non-segmental. That's a 22840 code for lateral mass screw fixation across one interspace. If you're using instrumentation across two or more levels or two or more segments, it's 22842, which is the vast majority of the codes for 3 to 6 segments. And if you're doing longer constructs, which are often done for deformity or other purposes, then it is a 22843 or an 844, depending on how many levels are being instrumented. Spinous process wiring has a unique code, which sometimes is still utilized in the cervical spine, and that would be 22841. There are unique codes also for removal and reinsertion of instrumentation. However, it's important to know that you cannot code for removal and reinsertion on the same case or same patient. If you're reinserting instrumentation, the code would be 22849. If you're simply removing the old hardware, then you would use one of the following 3 codes, 22850 or 852 or 855, depending on the extent of hardware being removed and whether it's anterior or posterior. It is also important to know that if you are exploring a fusion mass as part of your surgical procedure, you may not bill for the 22830, which is the exploration of fusion mass, along with removal codes or reinsertion codes, as they're considered bundled for the same process and same procedure. You can't perform a fusion without bone grafting. So if you're performing a fusion in the cervical spine, you're either using structural autograft, which is iliac crest autograft, and that code is 20938, or you may use morcellized autograft from the iliac crest, which is 20937. If you're using local autograft, that's a separate code from the same incision. It's 20936. As you can imagine, the values and the reimbursement for same incision autograft harvest are less compared to iliac crest autograft as a separate procedural code. Also, allograft can be utilized in the structural or morcellized form, and those carry their own unique codes as listed below. There can be other miscellaneous codes used in the cervical spine. For example, if you're doing a posterior approach for fracture fixation or dislocation fixation, that code is 22326. You can't bill that code along with a decompression code for work done at the same level. Odontoid fractures are unique to the cervical spine, and their codes are 22318 and 319, and this is for an anterior odontoid screw fixation. The 319 code includes an anterior bone grafting procedure for the defect caused by the fracture. Cervical disc arthroplasty is a fairly common procedure at this point, and if you're doing a single level arthroplasty, that code is 22856. If there's a second level or an additional level performed, that code is a 22858 code. There are revision and removal codes that can be utilized as separate codes altogether, as listed below. The difference between revision and removal is during the revision process, you will reinsert another arthroplasty by removing the old one, and the removal code is, as the name suggests, simply a removal of the old arthroplasty device. You can also do osteotomies in the cervical spine, and that has its unique code of 22210. There's an IND or infection irrigation debridement code in the cervical spine, which is listed below. There are some other billable procedures that you can code for. For the vast majority of government or Center for Medicare Services payment, microscopes are bundled with your anterior discectomy and fusion procedures. However, certain third-party payers may not follow the Medicare guidelines, although most will follow Medicare guidelines, and you might be able to bill for that microscope code. Fluoroscopy is a billable procedure, which is not just fluoroscopy, but really the professional fee of interpreting the fluoroscopic shots during surgery. Navigation carries its own billable code, and if there's a durotomy or dural repair performed during surgery, that again also has a unique procedural code attached to it. I know this is a lot and a dry topic, but it is very critical for you to code appropriately, and I recommend that you get yourself familiarized with the commonly used degenerative cervical surgery codes, and if there are any issues or questions, via email. And again, I encourage everybody to take the NASS coding course in their first year or two of practice, as that can really give you a head start on how to appropriately code without getting into hot water. Thank you.